for me to be invited. It just puts me in a humble position. And I'll just show you how I look at the endoscope from my perspective. So this is an updated talk, and I forgot to put 2023 here. Excuse me, but uh, I'm just going to show you how I look at the endoscope from my side. Anything we do in neurosurgery, we ask about data. And this is something that for trainees, there is no data. This is time you spend, you see mentors, you see how they work, and that's how you're going to learn. And don't depend on many papers because nobody is going to teach you the technique how you see it. So I like to define a tool first. So endoscope is a tool. I do endovascular, I do open vascular, I do endoscopy. I look at all those things as the tools. What is the best thing to do for this patient? And this is my philosophy, and that's why I put the definition of a tool, because it's an instrument in your hands and you use it the way you want, basically. Learn the anatomy. That's very important. Ask yourself what's the pathology, and then zoom into this patient. What is the best thing for this patient? And then generate a plan, make a strategy, make alternatives, and then master your tools. You'll be great neurosurgeon, whatever you do. So, nowadays we have to understand what we're doing. Life is changing. We're doing things differently. And this slide, I put it here to recognize, many as we see that I consider mentors to me. And those people have played a role into my training. In the center, Dr. Walter Grant, him and I visiting Dr. Hernes Niemi in Finland, trying to learn. And I want to emphasize that this is a long lifetime learning curve, that it never stops and just gets better and better as we mature as surgeons. And those are the people whom I consider as mentors to me, and I owe them for what I learned in terms of technique. So I'm sure this meeting spoke about a lot of advantage for the endoscopy, but I'm just going to be very brief here. But the scope gives you the different eyes. You can look from many angles, and this is unique for what we do. And this is something to be used for a full advantage. Disadvantage is there is risk of injury. This tool is so bulky, and I think we need a better design for neuroendoscopy to move to the next level. Just like endovascular, we didn't treat stroke until the devices came and became good enough for us to go after the clot and take it out. I think in endoscopy and ventricular endoscopy, we need that move next. And I think we will do great. So I talk about few things that people don't differentiate. There is the true endoscopic work where you're doing all your work through an endoscope. An endoscopic assist is just using it as an assistant device, and there is a guidance where it just guides you to where you need to get, and then you do what you need to do. And there is surveillance where you just put the scope and check on your work just to see what you did and what you need to do for the treatment. And this is where I use it with basically microsurgical clipping or whatever. And there is the transcranial and transnasal. Most of what I see now is transnasal. People caught up within the last 20 years on transnasal to the rest of the world. Transcranial has been stagnating a little bit. So, brief comparison with the microscope, the light is coming from above, it gets filtered. The endoscope, you're putting your eye right there, you're seeing much better. Basically, the endoscope is a little bit bulky. What tool can you put in? What side? What endoscope? What working channel? These are different brands. These are the sheath. I'm not here to advertise, but I simply used this thing, which is an NG tube, pediatric suction, 9 French, and I put it through this scope, and this served me great. I cut the bevel. I do bypass as well. And the people tell me the vessel is small, but if I cut it oblique, I make it bigger suddenly. And those slides just about principles. So the circle depends on the radius. So you can enlarge one of the radius to much bigger. So this is a cut surface, what we can make it to. I mean, you can stretch this thing to this thing and work with it with the endoscope. And this is how we look at it. And I did those just to proof of principle. So intracranial evacuation, this was the first system that was used. And if we don't get to intracranial hemorrhage as neurosurgeons, This is how, David Fiorella is a radiologist, so other field are gonna pick it up. Intracranial bleeding is a neurosurgical disease, and I don't think neurosurgeons are taking care of those patients, and that's why we see other people jumping into the field. People have used tubes and other things. All these are the tools, basically. But this is another paper from 11 years ago, Dr. Neil Martin, and this is what he used. He used the sheath of the endoscope. He put a tube, and then he would put his finger to suction the blood. He described his trajectory, eyebrow incision. Most of those hematomas are an elliptical like shaped on one side, and that's how he got into them. But nowadays we have tiny device that you can put through the endoscope. This is a sheath. And I'm just going to show you the first case I did this before all those devices came by. I just want to show you how painful it was and now how easy it is. So this is a 64-year-old man, a subarachnoid ACOM rupture, and he has a other aneurysms basically. But this is his CAT scan showing this is the hematoma. So it's far from the site of bleeding, and this hematoma for me is predominantly in the frontal lobe, even though it goes and traverses, this is the biggest volume. And if I clip this aneurysm or evacuate, I can't take out this hematoma and mass effect. So what I decided to do for him, this is his aneurysm. He has multiple based on the pattern of bleeding. This is the aneurysm that bled, irregularities, and epicenter of blood. So that's why we blamed it. We coil it, and we're extending the coil and until this is done. And this is what we did for him for the evacuation of hematoma. So as you see here, we took this blood out with an endoscope. So most of it is gone. But this is many years ago. And I have this video here just to show you how painful this was. And I'm not going to play all of it, but maybe small pieces. And I don't know if my video is playing for you guys. Okay, so this is the side that could happen. It could be many things with it. This is after this evolution that came by. This is a 34-year-old man. This is his hematoma. This is his aneurysm. And we coiled the aneurysm. And this is what we did with an endoscope, basically. Now, with this, we had the device. And I'm just going to share one of the video through this just to show you the big difference. Okay. So just bear with me. And I'm going to show you this. 1 second again. Okay. So this is now with new technology coming on board. Okay, let me move this. So it makes you dizzy basically, but this is the device. It has a cutting device on top of it, and it shakes in front of you, irrigation, but you engage a clot right there. Okay, and then you suction on it, and the tip of this tube has a cutting blade that will cut this fibrin clot. And you just work your way from the deep part to the superficial part. Okay, so I move it here a little bit, and then this is how it goes. You can get dizzy after a case like
Ri-
this.
Do you hear me, Rabbi? I'm
Yes,
sorry,
can you?
we can't see the video.
You
I
cannot
know.
see the.
No,
I'm
we hear
sorry
you
for that.
perfectly, but
Yes, so
something
let me try to share again. I'm sorry again. So present. I'm gonna you're in slow. Stop sharing. Share screen. Okay, I'm sorry. I'm gonna try again. Okay, so I'm just gonna go back to my slide. Okay, can you now see my slides at least?
Yes, the slide. Yes, perfect.
Great. So I'm sorry. I was planning to show you how new technology basically evolved, but this is the hematoma. You can evacuate it. And this is, this video is not gonna play. Okay, so this is the incision for the patient. It's a one burr hole, and this is the patient doing great, mild hemiparesis on this side. This makes a big difference for the patient, and this disease we have to get to it. The second set of stages, I'm gonna kind of go up in complexity. This is what I call staged, combined, microscopic, endoscopic. So this is a 42-year-old man, neurosurgery clinic for second opinion, large tumor in the pituitary. He had seizures initially, and that's how he came to medical attention. And ultimately, he has acromegaly, and this is his tumor. I'm just gonna scroll through the image and make sure we appreciate how big is this tumor. So this thing underwent necrosis. As we see, it's so big, and we see here the optic nerve falling down into this big cavity, the anterior cerebral arteries right there down and falling down in it. So this is a very complex tumor, and to my knowledge, it requires multiple tools to take care of it. And I think I have few more slices here. So this is the coronal cut starting from the front to the back. I mean, it fills the whole ventricular system right here. And as we see, the anterior cerebral arteries and optic nerves have herniated down into this big cavity and deficit. It's wrapped around both cavernous sinus, expanding high. So I'm not aware of any single tool that's designed to take care of this. So again, this is the T2 image. Here we appreciate the again the ACAs falling down. And this is the CAT scan showing how much bone erosion he has. So if we go here, how much defect we have to repair, and then the frontal sinus, which is massive, gigantic. So how to take care of something like this, and you appreciate here how he has even septations in his frontal sinus from the ethmoid. Something like this, I mean, overwhelming at first, but then once you simplify it, I said, I want to save it. I want to take out whatever I can get from a craniotomy. So this is the subfrontal and transbasal approaches. So what I did is subfrontal, and I decided to go transbasal if I'm ready for it. And I was able to see here, we see the Gallia, because I harvested the periosteum to repair the frontal sinus, and I went up from top and I took out anything I can, and I went down right here, and I could not get any additional angles to go to the sides from my approach. So I was able to take anything I can intracranially. This is the image. This was not a residual, but a little bit of a bleeding that converted, and this is a delayed scan. But we see here how I dug inside the tumor, and then we see here how I went down from the craniotomy. Second stage, he recovered his, IGF dropped down, but remained high. So I haven't cured this guy. So I decided to go from the nose, and this is the CAT scan showing again. We see the ACAs inside this cavity. So decided to go transnasal approach and an endoscope, and this is the procedure. Basically, him positioned and to all the extras, but the reference for the patient is deficit when I work
Can't see the video.
changing here. Can you guys
We
still
couldn't
hear
see
me
the
and see
video.
me?
Yeah, we see you. We hear you so, but we can't see. Now there's a little bit of video,
Okay.
like in the middle of the movie.
Can you guys hear me and see me? It looks like we lost
No, I think your Wi-Fi is.
Okay, so can you guys see me and hear me?
When you put the pictures, yes. When you put the movie, no.
Okay, can you see me now and hear me?
Yes.
Okay, it looks like whenever we use video, it just overload the system. So I'll try to. So in summary, we went transnasal from below, and this is the final result. And a combined approach using the microscope from transcranially and an endoscope from below really well, and his IGF dropped down to single levels. So um, uh, just confirming, can you guys hear me again?
I can hear you.
Yeah, Dr. Hakim, can you? Okay,
Yes,
can
we
you
can
guys
hear you.
hear me again?
Yes, perfectly.
Okay, I'm sorry. So endoscope and microscopes should not be a fight, okay? It should be this kind of very coordinated moves between tools to do what we can, and that's how I would like to look at those things. Advantage of the endoscope, I'm sure other speakers discussed, and I think we need to master what we use. Look at this osprey focused on his target, how his body alignment is in perfect trajectory to what he needs to do, and that's how we have to look at neurosurgery. And I like to put this paper because it talks about expertise randomized trials. People use randomized trials to see if this antihypertensive medication is better than this one. But how are you going to do it with surgeons and with tools? And it's much more complex. And that's why I think our surgical field is quite unique. So you can't randomize surgeon A versus surgeon B. It's just every one of us comes with a set of skills, and that's where we are. So now I worked my way to learn how to transform my transchoroidal approach, opening the Monroe a little bit more with an endoscope, so I can do more work inside the third ventricle. And if you look at the choroidal plexus, ultimately it's an infold basically from the lateral ventricle to the third ventricle. Anatomy you have to be aware of is fornix. Okay, the tinea choroida or tinea fornicia. I mean, this is not a tissue that you worry about. Internal cerebral vein you worry about. Thalamic vein, thalamus striate. Okay, but this is a almost a dead space, and the approach to it has been basically pioneered by microsurgery. I'm sorry, but this is how it is. So don't mess up with the thalamus striate vein. Septal vein, I think you can take it out unless it's really big, but this expands the Monroe significantly. So this is what I tried a little bit more. So I tried to expand the foramen of Monroe posteriorly, and I trained myself in the lab, and I was lucky. I had training with Dr. Walter Grant. Unfortunately, he passed 4 years ago, and he's not with us anymore. But I owe him big time, and he learned endoscopy from Dr. Perneski in Germany, and he was friend with Dr. Grotenhaus, and we found ourselves doing the same, and we put our case series together. So this picture, I like to use it is this is the third ventricle. So this is anterior, posterior mammillary body. ETV, we do it routinely from the Monroe. But look how much of the third ventricle we use. If you want to angle the scope posteriorly, I have been limited by the massa intermedia. Sometimes it's bulky, and I never had enough courage to go through it. I respect it. I don't want to touch it. But look how much we can navigate from our standard approach. That's it. Okay, if you need to go to the pineal region, you need to go more in different trajectory to target this area. So we're limited through the Monroe. Now if we can expand this opening here, this trajectory will allow us to get back. Okay, and this was the theory behind what was done. So let's look at this case. 22-year-old woman. Basically, she has this pineal mass, obstructive hydrocephalus, and what she needs is an ETV, and she needs a biopsy. And both can be achieved through a simple procedure. Ultimately, I think I ended up doing two approaches on her before I started expanding the Monroe. And I'm just sharing with you cases where I learned uh, and how I evolved into this. I hope I don't lose connections with this video, and maybe I should just not play it. But this is what we did with her, uh, basically. Um, so we expanded the Monroe. So this is a complex of a navigation system. You have a scope holder where you can adjust, and it's very hard to rely on a machine to help you out with this. Okay, so this is a colloid cyst, how we take them out, basically. So those colloid cysts, you have to decide which patient. So I don't have a magic incision. For this patient, if this person presents to me as a patient, I'm not going to do an incision in the forehead. If this is the patient, I'm just going to find this. So you have to adapt and adjust to a specific patient, basically. And I'm just confirming that you guys hear me again. So, Dr. Hakim, do you guys hear me? Okay. Can you guys hear me?
Yes, we can hear you perfectly.
Wonderful. So I'm going to continue going. So I was, again, I'm sorry the videos are not playing nicely, so I'm just trying to skip them. So this is a colloid cyst. Everybody has treated this, but I don't know how to do surgery for colloid cyst with a microscope. Every time an endoscope serves very well, and I think it's a great tool. In my training, that's how I was trained, and that's how I was carrying it basically. And I'm hoping that this video will play a little bit more because I want to show you how I expand it a little bit. So the choroid cyst is right here. Okay, and this is not expedited. This is the real time for the procedure. So coagulate the choroid plexus would be the good thing to do as a person then coagulate the plex. Basically, I'm just gonna move forward. So this is the coagulation. We resect choroid plexus. We can see a little bit more. We can take the choroid plexus. Next thing, expose the veins, the thalamus striate vein and the septal vein. And I'm resecting them. So here's the forceps, very gentle with the forceps. Grasp, don't overdo it. Be very gentle. Rotate right, rotate left, and the patient can give up, basically. Okay, some bleeding that we can control with the Okay, so now this is the old device, the suction that I modified myself, so we can aspirate and clean some blood. Okay, so coagulating more, expose the capsule. So here we see the capsule of the colloid cyst, and I'm grasping on it. I'm trying to pull very gently and very carefully so we don't rip something and we don't lose the capsule. And ultimately, this is the cyst. We emptied the contents, we aspirated them, and as we see now, the Monroe is much longer and bigger space, and we take out the colloid cyst. So let me show you the final step. So this is the cyst, okay, and this is the final result basically. Colloid cyst is out, and the patient does very well. I leave a catheter, and as we see here, there is an EVD catheter. So this is the follow-up at 10 months, and the patient is doing great. Okay, so system steering, and what system do we need to use for those cases? Endoscope holder, like what is the best? There's nothing better than in a good hands, good sets of hands to help you out. A colleague, partner, a senior resident, or somebody who's tuned to hold the scope and help with those cases. Okay, so this case is I'm going to show the endoscopic assistance. So this patient had hemifacial spasm for 20 years. We see a vascular loop inside the auditory canal. Okay, and we see the loop here. Okay, and this is the loop going inside on the MRA. And this is very nice T2 slice showing the anatomy in great details. So this is the microscopic view as good as it can get, and this is the endoscopic view. I'll just alternate a few times. I mean, there is no comparison between this and this. So the endoscope is inside the internal auditory canal, and this is the vascular loop. And this is right there. I mean, I can see the individual nerve fibers going inside. All right. I'm just confirming that you guys are still hearing me as well.
Yes, we're hearing you.
Wonderful. So I'm going to keep going. So this is the microvascular decompression, and we separated the vessel, and these are the endoscopic views after the job is done. So you can confirm your work and you can check on everything. This is in another case with when we used for a PCOM aneurysm. 2 years after pipeline, the patient still have an aneurysm. So this is the aneurysm, and it's a fetal PCOM. I don't think flow diversion should have been used in this case. We see she had an MCA clipping before, and this is the flow diversion that somebody put in. But because there is flow demand on this PCOM, this aneurysm will never shut off. So let me show you the slides. This is her images back from 14. So this is the MRA showing persistence of the aneurysm right here. And this is the lineup. So if we go back 2006, 7, 12, and 15, what you see here is a white line. This is endothelium covering with the pipeline device, but still there is some holes and flow need. When the blood goes inside, the neck of this aneurysm is shared. As we see here, part of it comes from the PCOM. Even if you shut the flow from the ICA, it's still going to fill from the PCOM and it's not going to go away. So a solution for this, and we see here the endothelium, the neck from the carotid is gone, but still filling from the PCOM. And this is we did Alcock test. There is no filling of the PCA from the vert. And again, this is the aneurysm. So we did surgery, and what I end up doing is a fenestrated clip around the flow diverter, and then this shuts down the aneurysm. And this is the peak. This is the PCOM still filling. So this is the view. I'm just gonna quickly go to the. So here is me detecting the right. These are oil. Actually, this is that was adhesions here. This was a ruptured case and a residual. Then watch our microscopic views, and then next thing we're going to see is the endoscopic views. Okay, so look at the level of knowledge you have. So these are the out look deep. Now I know exactly where my clip is gonna go, and I'm avoiding all the perforation. So we're readjusting again, and needed to make sure I cover the whole thing. And after clip placement, you can re-verify if it's still patent. So it's, 2 years just gives you a great knowledge. Okay, so it looks like I lost you guys for a second or so. Okay, I'm sorry again for the connections, but I was trying to show the assistance from an endoscope with clipping of those aneurysms. And this is what I think the future of endoscopes. I think all those things are going to become a small chip that maybe you can put it with a biceps or a forceps down in your operative view and just going to give you another camera in your operative cavity. And that's how I look at this maybe, I don't know, 10, 15, 20 years from now. And that's what I'm hoping. And those are the small chips that are going to get us to visualize the operative bed. So um, with this, I would like to thank everybody. And again, I just learned from my mentors, and I carried this task without being afraid from the anatomy, knowing the anatomy, and using all these tools as to help me get a better outcome on my patients. And knowing what I know, if I'm the patient, I would use all these tools in conjunction. So I'm not only an endoscope guy, but I really appreciate being invited. And if we have to love anatomy, this is Professor Evandro de Oliveira. Probably within 16 months before he passed, you see him in the lab, in our lab here in Florida. He's just enjoying the anatomy and learning. And I think if we develop this kind of mentality for our future generation, I think we'll do great, and I think we will serve our patients very well. And this is the date for our next upcoming course. I would love for you guys to come and attend and hope to see everybody. And thank you so much.